Finally, the time has come. You no longer have to choose between conventional medicine and alternative medicine. Today, unlike years past, your team of doctors from all disciplines are working together side by side for the benefit of you, the patient, to help you regain your health and cross the bridge.
Hello again. Welcome back to the Bridge to Health. My name is Dr. Tom Dow. And this week we have a very, very exciting guest with us. But before we start with our guest, Dorland's Medical Dictionary defines health as a state of optimal physical, mental, and social well-being, and not merely the absence of disease and infirmity. So what that means is, just because you don't have a disease, just because you're not diagnosed with something, unless you have three things which are optimal, your physical state, your mental state, and your social state, you are not in optimal health. How many times have we heard someone say, I have no pain, I have no symptoms, I feel great, and bang, we find out that person drops dead of a heart attack. So even though they felt good, even though they might have looked good, even though they may have been exercising regularly, eating well, there's more to health than just outward appearances and lack of symptoms. Each week we have a guest from a different discipline to try to explain to you, the audience, what these different disciplines do in their everyday practice to impact the health positively of you, the patient. And they're part of our healthcare team that we consult with on a regular basis. Today, I'd like to introduce Dr. Sal Trezera. Hi, Dr. Trezera. Thank you very much for joining us today. Dr. Trezera is a cardiologist, but a special type of cardiologist, not your regular cardiologist. Dr. Trezera, can you tell us a little bit about what makes your practice and what you do much different than most cardiology practices?
Sure, Tom. First, I'd like to thank you for having me here today. It's a fun and exciting thing to do. My practice of cardiology started out as any conventional cardiology practice would, doing interventional procedures and cardiac catheterization, putting in stents, and treating disease for many, many years. Along with that, out of training, we do stress testing, different types of stress testing, cardiac monitoring, and clinical cardiology, treating patients with medications. Mm-hmm. But over the years, as we continue our education, both through what we learn from our patients and from continuing medical education, what I've learned from all the different sub-disciplines within cardiology is that cardiovascular disease is an integrative type disease. And we have to start to not look so much at testing and results of testing, but more at what the metabolic issues are. What are the things, like you said, behind the scenes, things that don't necessarily initially cause symptoms, but are risk factors, maybe metabolic risk factors, hormonal risk factors that put our patients at risk for developing heart attacks and cerebrovascular disease and strokes and things like that.
Right, so Dr. Trezera, when you say metabolic risk factors, are you talking about, like, you'll have a patient come in, you'll do a lab work or a blood test on them, a profile, which is measuring certain hormones or certain enzymes or certain things that would give you an indication as to their likelihood in the future of having a cardiovascular event. Is that true?
That's correct. You'll find that when you go to most primary care physicians or most conventional cardiologists, blood work that's done is very basic blood work. Complete blood count, metabolic profile, which only looks at really kidney and liver function, possibly thyroid function tests, and maybe a cholesterol level. Well, there's much more to it than just that. We find that certainly as we age, things change from a hormonal standpoint. Testosterone levels wane in men, just as estrogen levels wane in females. Cortisol levels, which are stress hormones, insulin levels are extremely important in our society and population due to our diets and the problems that we have with our diets. things like the prostate-specific antigen in males to test for the possibility of impending prostate cancer. IGF levels, which measure your growth hormone levels and your ability to heal. And then, of course, there are other non-invasive ultrasound tests that we can do that will show us disease earlier, give us kind of a picture of what the coronary arteries might look like by doing simple ultrasound.
And this isn't something a regular general cardiologist would look at, correct?
Correct. In general, if I were to solicit blood work on one of my patients that was done at another office, I'll get that blood work and I'll see very cursory basic things, CBC, metabolic profile.
Right.
Many of my male patients that come in, they'll just come in with fatigue, and they don't necessarily offer you the fact that they have erectile dysfunction, or they have low libido, or they're not able to lose abdominal fat, they can't exercise and recover as quickly. Unless you solicit that from them and ask them specifically, you'll find that most males, 40, 50, and 60, actually have developed that, and many of those symptoms are related to abnormal insulin levels, abnormal testosterone levels, cortisol levels. And if these things are actually optimized, their whole quality of life improves, their ability to function improves.
Okay, so I think what you're saying, we understand this, is that you have the ability to run specialized tests to assess these levels, which we call risk factors for cardiovascular disease. Then, let's say you have abnormal findings in those, do you then have treatment recommendations to bring them back to a normal level?
Absolutely.
So that their risk factors now decrease?
Yes. The goal is to be integrative and comprehensive. With all my patients, I try, or I will, speak to them about their diet. We'll look very extensively at what they should and shouldn't eat, how often they eat. Many people believe that they don't eat much, and that's a bad thing. They may not be taking in enough calories or appropriate nutrition in order for them to lose weight. That's a misconception. People think that, oh, if I eat less, I'll lose weight. Well, not necessarily. That depends upon when you eat, how much you eat, and the hormonal circumstances that occur because of your diet. So the diet, we spend a significant amount of time at looking at the diet. We also spend a significant amount of time talking to them about exercise, specifically aerobic and strength training, which are paramount in both males and females from the standpoint of aerobic and cardiovascular health, and then bone health and muscle health. For instance, in women, the fact that they get osteoporosis, they should be lifting weights.
Right.
I have women at 70 and 80 that are, for the first time in their lives, doing strength training that never did that before.
They're probably one of my patients I referred to you.
It's possible. It's possible. So you have the diet, you have exercise, okay, and then we do our blood profile, and we also would do some testing. Generally, it's things like EKG for baseline. We'll look at their exercise tolerance on stress testing, and sometimes we'll even do cardiopulmonary stress testing, which is more extensive stress testing, enabling us to assess what their metabolic needs are, how many calories they need to take in every day, what will happen, to their oxygen consumption when they're exercising, as well as the other thing that we do also is we look at their body fat and lean body mass content. We try to look at that and say, hey, let's start you here where your body fat may be 35%. These are the things we want to implement so we can get that body fat down.
Right.
Specifically because abdominal and visceral fat, okay, you look at most Americans walking around, that's a big problem that causes increase in inflammatory markers, increases in vascular disease.
Right.
So that's why we're trying to fix the whole metabolism and get people on that type of regimen.
So now let's say you find a patient and they have hormone imbalances. Let's say they have low testosterone levels, they have low growth hormone levels. Would you recommend them increasing those levels with therapeutic treatment?
Yes. As far as testosterone in males, generally the levels are, depending upon the lab, are felt to be anywhere between 250 to 1,100 picograms per deciliter. When you're 25 years old, your levels are 800, 900, 1,000. When you get to be 50 and 60, your levels maybe go down to 200. But those are still considered to be normal levels.
Right.
But when you're 40, 50, and 60 and your levels are 200, 300, even though they may be at the lower limit of normal as measured, they're not in an optimal circumstance. And what we know is that testosterone levels, as they drop below 500, okay, there's an increase in cardiovascular disease.
Wow, so there's an increase.
Absolutely.
It's interesting you say that, because years ago, cardiologists were proponents of telling people, bodybuilders, athletes that were on testosterone therapy, that it's bad because it'll give you a heart attack.
Well,
years ago, right? Am I right?
That's true. There is no truth to that, because at the other end of the spectrum, I don't want testosterone levels to be 2,000, 3,000, 4,000,
right.
because that does promote cardiovascular disease.
Right.
So I have the gamut of those ex-bodybuilders, athletes who have abused anabolic steroids, who have basically shut down their own production, who've developed disease that have to be addressed as well.
And your job is to get it back into that normal range.
Correct. What
and
we want
maintain
is
it there.
Right, appropriate, optimal physiologic levels of testosterone and estrogen too for males. Okay,
Right.
your estrogen levels, as your test levels go down, your estrogen levels go up, and that's
Right.
not good for male either.
Right.
Okay, because that causes issues as far as abdominal fat and whatnot. And on the flip side, the female, believe it or not, as they go through menopause and their estrogen levels go down, their test levels may either A, go up, or B, go down. And you can treat females with testosterone at times, low levels of topical testosterone.
So you have females that you recommend testosterone therapy for?
If they have, depending upon their circumstance, sometimes it can. It will help with their lean body mass, it will help with body fat. Sometimes it's women that have osteoporosis. It's an anabolic hormone, okay, which if given in the appropriate dosages and monitored is perfectly safe.
Wow.
And done all the time.
I read a couple of research articles years ago, 2-3 years ago, that they were saying that people with heart failure, cardiac myopathies, just heart muscles that weren't working well, that they were actually giving these people some form of testosterone therapy.
Yes.
And it helped rebuild the heart tissue?
Absolutely.
Is that true?
There is a host of literature on congestive heart failure patients and the treatment utilizing testosterone. You're absolutely right on the money there. Low testosterone is an exacerbating factor in patients with chronic heart failure. So, and you look at these patients and their testosterone levels are 75 and 100. So if you put them up to 500, 600, it helps. It helps them exercise and recover.
So just like any muscle that's going to get stronger, the heart will too, right?
Correct.
So I have a question for you. So on Long Island, let's say, how many cardiologists do you think practice and look at these kinds of things and reinforce these lower levels to help cardiac health in the ways that you do?
One.
Just you?
Yeah, I'm not aware of many cardiologists that have shifted their practice. There are cardiologists who may be lipidologists or into metabolic medicine to some extent, and they concentrate on high cholesterol and whatnot, which we're evaluating as well. But the comprehensive nature of what we do from an imaging standpoint, my career has spanned both invasive and non-invasive cardiac modalities. In my training, I did over 3,000 cardiac catheterizations and cardiac interventions.
I was one of them.
Yep. And we saw disease, okay, directly with angiography, right? Going through the
Right.
groin and looking through x-ray. And at the same time, we did what's called perfusion imaging, which is stress testing with isotope looking at blood flow.
Right.
And I learned over my many years of practice that what we saw on coronary angiography was only the tip of the iceberg. Coronary angiography only shows the internal lumen of the artery.
The inside.
That's correct. Okay, coronary angiography historically has missed much of the early disease that is within the media and adventitia of the artery, where calcium deposits start, where lipid collection starts.
So just so the audience understands that, I believe what that means is if you look inside of a hose and the hose looks clear, what Dr. Chazer is talking about is in the rubber of the hose that you can't see if you look in the hose is where that disease starts. Is that correct?
That's correct. What's evolved now in the last 10, 15 years, and now since we've had better and faster computer technology, is cardiovascular computed tomography, or CT.
I was just going to ask you about that.
It's a very exciting discipline. So I was able to evolve with angiography, stress testing, echocardiography, and now to our best imaging. Our best imaging now is cardiac CT. We are able to detect coronary disease in the very early stages, long before you have symptoms.
Right.
And you ask the question, well, who would get that test? It's very simple. You just have to do a risk factor profile. You have to look at the patient, their diet, their weight, their family history, if they have high blood pressure, if they have high cholesterol, if they have diabetes, if they're a smoker, what's their lifestyle. If you look at these several risk factors, you can look at that patient without ever touching them, putting a stethoscope on them. You just ask those questions, and you will know with probability what the likelihood is that they have early coronary disease, which is undetectable because they've eaten the American diet, okay, for their lifetime. Those patients should be scanned both with what's called calcium scoring, okay, which is when we do that CT scan, which is very quick, okay, in the scanner for 5 minutes, it's very low radiation. We're able to see calcium within the arterial wall, and at the same time, with an injection of contrast, we will get a non-invasive angiogram, just like when we used to stick the catheter in the groin.
Right.
So we can see disease at 10%, 20%. That's so important because the 40 and 50-year-old guy who's asymptomatic, who drops dead on the golf course, at a bar mitzvah, on the dance floor at a wedding, okay, after he just had a normal EKG, okay, and a normal physical at his physician's office, we can pick up that disease when it's 20%, and we can say to the guy, look, you have disease. It's very impressive to one when you know that there's disease. Much more likely that that patient will comply and take aspirin and or a statin if they need to change their diet and their lifestyle, which will prevent that from progressing and prevent heart attacks and prevent future events. So that's why what we do is different.
I first met you, I believe it was around 20 years ago. And
when I had hair.
Yeah. And I met you about 20 years ago, and the reason why we met is because I had a buddy of mine, my best friend JR, at 39 years old, after going out in my boat on the 4th of July, he went home, laid down in bed, and suffered a massive coronary and died that night. At 39, no prior history, no symptoms. When they autopsied him, he had I think what they call congenital cardiovascular, all of his coronary arteries were blocked. He did have a family history of it. And I came to you and I said, look, I have no symptoms, I want to make sure I'm okay. And we did all the tests, and all the tests came back normal, except for one test, which might have been an artifact from my chest size, which was humongous at that time. And you said the only way to be sure was to do a catheterization.
Right.
And we did a catheterization. Catheterization, by the way, for those of you in the audience, a catheterization is when they put a probe or a catheter into the groin, which goes up to the heart and then goes into the vessels and looks at all the vessels in the heart. So we did that. Everything was clear. So my question to you now is this cardiac CAT scan, which is done now, which is more sensitive than just a catheter looking inside and not in the lumen and in the walls, is that a replacement for a catheterization?
I think that it will not replace the catheterization because catheterization will be always required if there's disease of the necessity to intervene on. So if a blockage is 70, 80, 90% and you require a stent, you need a catheterization. So it will not supplant the catheterization, but what it will do is it will change the amount of unnecessary catheterizations that are done.
So if they would have done that with me, I never would have needed that catheterization.
There will be less normal catheterizations because we're not going to do catheterization on a guy who we did a CT scan on who has a 20%, 30% stenosis. There's no necessity to put him through that procedure. Now, let's go back 20 years. At that time, we used a cardiac cath. And in essence, we were correct, because 20 years later, we're sitting talking to each other. You're still alive, right?
Right.
Okay. As far as I can see, right? So, but what I've learned over that 20 years is, from that is, now that we've evolved to cardiac catheterization, okay, there's a different way really to proceed. And it turns out that we, at St. Francis Hospital, we will be opening a new cardiovascular imaging center at St. Joseph's Hospital, which is a community hospital in Bethpage. Should hopefully be open by the 1st of 2016. It will have a Philips 256 slice cardiac CT, which is state-of-the-art. The $2 million machine, and we're going to be probably the first community hospital, in the metropolitan area that's able to actually provide this level of care under my direction, along in partnership with St. Francis Hospital and Catholic Health Service. So we're very excited about that.
Nice,
And
nice.
I think it's going to make a big impact on
Where's your office, Dr. Trezere?
My office is in Farmingdale. It's 206 Fallwood Parkway, Farmingdale, New York.
And your phone number there?
My number there is 516-249-1020.
And do you have a website?
I do. It's farmingdaleheart.com.
Excellent. So, another question.
Mhm.
I had a patient come in 3 or 4 weeks ago into my practice, had a car accident, and one of his symptoms after the car accident was, well, since the car accident, I felt shortness of breath, I have pain down my left arm, I have pain in my chest, and immediately I told him, you need to go to a cardiologist right away. Have you ever been to one? No. This guy was probably 55, 60 years old, so you need to go to a cardiologist and you need to be checked out. He needed a referral from his primary care doctor in order to see a specialist, so he went to his primary care doctor. His primary care doctor ran an echocardiogram on him and told him everything's normal, you don't need to go to a cardiologist. Do you agree with that?
Well, obviously I'm biased, but I'll tell you the reasons why I think that any patient that has a motor vehicle accident should be evaluated by a cardiologist. First of all, not every motor vehicle accident has a driver who is restrained. Okay, so if they're not restrained, oftentimes they can hit the steering wheel, okay, and cause some anterior chest wall trauma, which could cause sometimes as little as a cardiac contusion, okay, which may be causing his pain, which is musculoskeletal and/or cardiac in nature. The other thing too is in significant deceleration injuries and significant motor vehicle accidents and also motorcycle accidents, you can cause a microdissection, okay, at what's called the isthmus, okay, where the aortic arch and, and the ductus arteriosus or embryologic life. There's a ligament, and because of deceleration, there is a shear force that can actually cause a tear. Now, if you're in a major accident, that is basically how the aorta becomes transected and people die instantaneously.
Right.
But if you have a micro tear, it may be years before you develop an aortic aneurysm. And very interestingly, if you look at retrospective reviews and studies on people who present in their 50s and 60s with aortic aneurysm, there's a more than likeliness that they may have had a major car accident years ago.
Wow, interesting.
So that's why you have to have it.
And can you diagnose that with a test?
Well, you could, if you can, absolutely. On a CT,
on a
if there's
scan?
Yes, if there's a micro tear, you can. It's something that, more importantly, the cardiologist thinks in a certain way. When there's a chest wall injury, this is what comes to mind. So I know that this is what I need to exclude.
Right.
Whereas a non-cardiologist doesn't necessarily have that thought process. And we'll constantly surveil that over the years to make sure that there wasn't a micro tear, maybe something that we can't see, okay, now, that may develop over time.
Okay, let's make believe there isn't a car accident. Patient goes, complains of chest pain, left arm pain, shortness of breath, and wants a referral to a cardiologist. Primary care doctor does an echocardiogram and says you're fine. What are your feelings about that? Because I have my feelings about that.
The problem with it is, number one, when one has chest pain, you have to choose the appropriate test. And echocardiography isn't the appropriate test to exclude coronary artery disease.
Right.
Okay, it's an appropriate test in the evaluation of chest pain to rule out the possibility that you have pericardial fluid, abnormal wall motion, a valve issue, pericarditis, a host of things. But a normal echo doesn't finish the workup for chest pain, because that's only looking at the structure.
That was my point. It's
The
one
arterial
test out of
disease-
many we need
Exactly,
to do, right?
Exactly. And again, that if you take that chest pain patient, you have to closely interrogate them about their risk factors, because that will enable you to decide, are they low risk, intermediate risk, or high risk patients.
Right.
And by categorizing them into different risk categories, the probability of them having an adverse event is, dependent upon what you need to do from an investigational standpoint. High risk patient needs to go potentially to the cath lab.
Right.
Low risk patient may need, a stress test.
Right.
Metabolic workup. Okay.
And that's what you do best.
Correct.
in your
We
practice.
try to risk stratify the patient, and we try to do the appropriate test when it's indicated, and then give them, a plan going forward. When they leave the office with a normal workup, 99% of those patients, that only means it's normal. Now, if they're obese and they're diabetic, they still need to.
You got to address
make
those
the
risk
changes.
factors,
Exactly.
which is
Those
what
are
you
the-
do in your practice
Exactly.
the best.
We try.
Well, Dr. Trizera, I want to thank you very much for being my guest today. I'd love to have you back again soon.
Love to come.
All right, and for those of you watching us
Appreciate
on Madhousetv, we'll be right back. For those of you watching us on Cablevision, stay tuned, and we'll see you next time. And just remember one thing: if you want real wealth, join us next time on The Bridge to Health.
Finally, the time has come. You no longer have to choose between conventional medicine and alternative medicine. Today, unlike years past, your team of doctors from all disciplines are working together side by side for the benefit of you, the patient, to help you regain your health and cross the bridge.
Hello again. Welcome back to the Bridge to Health. My name is Dr. Tom Dow. And I have a question for you, the audience. Health, health, health. What is health? Many people have many different opinions of what health is. Some people think it's looking good, looking in shape, not being overweight. Other people think it's feeling good. Other people think it's eating good. And other people have no idea what good health is. Dorland's Medical Dictionary defines health as a state of optimal physical, mental, and social well-being, and not merely the absence of disease and infirmity. So what that means is, just because you're not diagnosed with a condition, a disease, just because you're not infirm, which means just because you're not sick, does not mean you're in optimal health unless you're optimally physically, mentally, and socially fit. And I'm sure we've all heard the story of a trim, fit athlete, eats well, looks good, feels good, and boom, guy drops dead of a heart attack the next day. So, and we've also heard the story of a guy who's killer pain, got a toothache, needs a root canal, can't sleep, migraine headaches, and even though that patient's in tremendous pain, he's not going to drop dead from that pain from a root canal in all likelihood. So the way you look, the way you feel, and the amount of pain you have really has no impact at all as to the state of health you're in. Today, I'm honored and pleased to have a good friend of mine, a guest. Our guest is Dr. Robert Brevar. Hi, Rob.
Hi, Tom. Thank you for having me.
Good to see you, Rob. And Rob is a chiropractor, just like I am, who has a multidiscipline health center. And Dr. Brevar, can you tell us a little bit about your center and what kind of specialists you have there and what you do there?
Of course. We've been in Westbury. September will be 17 years. We've got medical doctors there, physical therapists, chiropractors, acupuncturists, a full-time audiologist, got an orthopedist. We treat about, give or take, about 300 people a week, and everything comes in there from neck to back to shoulders, carpal tunnel,
right,
surgeries, pre-surgeries, post-surgeries, trigger point injections, you name it, we pretty much seen it.
Right. So you have a center, just like our 4 centers, which are integrated healthcare teams.
Oh yeah,
that work together,
yes.
That on a daily basis consult and talk about your patients, so that you each know what each one's doing to give them the best possible care.
Of course.
And do you have regular meetings or or consults with the professionals in your office to discuss your patient care?
Every day. Patients come through the door, multiple doctors can take a look at a chart, figure out what's going on, who could work best. Is it one, the other, or is it all of them put together? Get the best approach for the patient.
Good. And have you seen patients that look good, feel good, and are in bad health?
Of course, yeah.
And what's the biggest thing that you see with people that look good, feel good? Heart conditions, allergies, diabetes. Do you see those kinds of things?
Well, yeah, we'll get a patient walks through the door and they'll say, you know what, I feel great. And I'll say, listen, you look good, you feel okay, but you have a heart attack tomorrow. How'd you feel the day before? Or you get diagnosed with diabetes tomorrow. How you feel right now? You feel fine.
Right.
Generally, how you're feeling and how you're healing aren't always connected. So
Right.
some people look great on the outside, but on the inside, they're kind of falling apart.
Right.
And it's a good thing because once in a while they'll get a little pain here, or I get some tingling in my hand here, and that brings them through the door. If they never did that, we wouldn't know, and I couldn't diagnose them and tell them that they got more problems going on.
Right. So, so you have a patient come in. They have a car accident.
Yes.
They have neck pain. They have pain down into their arm. They have numbness and tingling in their hand. What do you do from day one to work up that patient?
Well, first thing, patient will walk in, have a consultation with a doctor, always with a doctor. They'll sit down, whether it's 5 minutes or an hour. They'll figure out what's going on, what they need as far as diagnostics, EMGs, CAT scans, EMGs, whatever they may need at that time. Doctor will work up a chart, we'll do the exam. They'll come back on the second day generally for a report of finding. We'll sit down with them, we'll go over their x-rays, we'll go over their exams. We'll tell them this is what you've got, this is what we found, and this is what we need to do with you.
With your team?
With the team, of course.
Right. What's an EMG? Explain to the audience what that is.
So basically, it's a simple diagnostic test. It's an electromyogram, nerve conduction. It checks for compressed nerve, checks for numbness, tingling, paresthesia. Oftentimes patients have tips of their fingers. They say, I fall asleep, my hands go numb. Why is this? We give them an idea of where it's coming from, whether it's coming from the neck, coming from the wrist, carpal tunnel, or a brachial plexus, for example.
Right. And so now you begin a treatment regimen with different members of your healthcare team, such as?
For example, a chiropractic or an orthopedist, physical therapy sometimes. A person may need acupuncture or a combination of all three or four at the time.
Right. So you're basically, like we do in our 4 offices, we're giving the patient the best as we can, like from an a la carte menu, to give them the best chance of
Absolutely.
Recovering and getting better.
It's not the kind of
Right.
practice, if you need this, you go there, or if you need this, you go there. Pretty much everything's under one roof. Makes it a lot easier for a patient.
So what I found in the past years, decades ago, I've been out there a little longer than you have, was that it used to be a patient would come into us, and if they've done physical therapy or they're doing physical therapy, they now come to us, and there was a battle where the physical therapist would say, you don't need chiropractic, you need physical therapy. And other chiropractors would say, you don't need physical therapy, you need chiropractic, with different approaches, where the chiropractor says it's the nerves and the physical therapist says, no, it's the muscles. And there was always a battle years ago. Patients ended up totally confused of, man, what should I do? Whereas today in our offices, they don't have to choose. They get the best, and usually they can have both done at the same time, to give them the best chance of getting better. As I explained to my patients, that if you just get one or the other, and the chiropractors that are out there just doing chiropractic are probably going to kill me for this one, but my opinion is that if you just get one without the other, either therapy, physical therapy, or chiropractic separately, you're not getting the best result, I don't think.
Absolutely.
So, for instance, you have a patient come in. They're acute. They have a killer neck pain, recent car accident, acute inflammation, and they have moved bones out of their neck, which we call subluxations, which are pinching nerves.
Yes.
First thing we want to do is what with that patient?
Well, first thing you want to make sure you diagnose them correctly.
Right.
Figure out what's going on, whether it's x-rays, again, MRIs, have them come in, we'll sit down and say, this is what you've got, this is what we need to do. Once we figure out what's going on, to say this person might be a good candidate for physical therapy.
Right.
Physical therapist starts a protocol once a week, twice a week, whatever.
Cut the inflammation down, cut the swelling down, cut the spasm
the
down.
medical doctors on staff,
Right.
they can hand out anti-inflammatories, muscle relaxers, painkillers, whatever they may need if they need anything at all.
Right.
If a trigger point injection might be needed to reduce the inflammation, if they're so acute they can't even go to work or they can't sleep, the
Right.
doctor can step it up.
Right.
We can send them in for some stim, some heat. Physical therapists can do what they do. And having the chiropractor, the physical therapist, and the acu all under one roof,
Yeah.
Everyone gets a piece of the pie. It's not
Right,
just
well,
go there and go home.
Yeah.
It's
And what happens is, by that therapist working on them, or medications, or whatever it is, to decrease the spasm, decrease the inflammation, it makes our job as chiropractors easier
Oh, much easier, yeah.
to move things back into place so that so we unpinch the nerves, so that we can correct the cause of why all those things are bothering to begin with. Do you agree?
Yeah, it's not a tug of war. There's no you pull this way, I pull that way. We're all pulling in the same direction for the patient. It doesn't
Right.
matter what's good for me or what's good for that guy. It's what's good for the patient. Let's do what we need to do symbiotically so that patient can
Right.
get the best results as fast as possible.
So now what happens is the therapy people decrease the spasm, decrease the inflammation. We're able to now put them on a treatment plan and little by little move these bones back into the correct position to correct the subluxations, unpinch the nerves, which are causing the muscle spasms. And now, after we get a decent amount of correction done, the therapist now can have them exercise to strengthen the muscles to hold the bones where they need to be now, correct?
100%
So
correct.
one complements or is symbiotic to the other, right?
Absolutely.
So what I tell patients, if they're, well, I'm doing physical therapy, I just want to keep doing physical therapy, I've done their x-rays, I've shown them that their bone's out of place, and I ask them, well, what do you do in physical therapy? If it's not in our office, if it's somewhere else.
Mhm.
Well, they do the stim, they do the heat, and then they exercise. And the first thing I say to them is, You see those x-rays where C2 and C5 is rotated, out of place, pinching a nerve? I say to them, why would you want to strengthen muscles and exercise to hold that structure out of place?
Yeah.
Do you find that too?
Sometimes we'll get a patient walk through
right.
the door, yeah. They'll say, my back hurts, so I went to another therapy office, and they'll tell me, they put me on the treadmill for 20 minutes, then I did that exercise and that exercise. And I said, but you had pain. And they'll say, yeah, you had a lot of pain. I go, well, why are you exercising when you have pain? Was it getting any better? They'll say, no, it got so much worse. And I'll say, well, why did you keep exercising to make it worse? They're like, well, they told me to.
Right.
So working with a therapist instead of against a therapist, I'll say, listen, why don't you come in here, let us show you. First thing is first, we'll get you out of pain. Step two, we'll start to make some corrections. We'll make corrections. We'll put things back to where they belong. Take that bone, hypothetically, off that nerve. Put the bones back to where they belong. And once you're out of pain and the bones are back to where they belong, we'll strengthen you. Now we'll give you the protocols to go home and exercise to keep this like it's
Right,
supposed
you
to
want to
be.
make the correction first. You want the structure. Now let's do a little exercise to hold what we just
Absolutely,
did, right?
absolutely.
Instead of gluing something in place that's not corrected.
Yeah, I tell patients,
Right.
if you come in my office and you've got a rock in your shoe, I'm not going to say go on my treadmill and run 5 miles. It's going to get worse. If you come back the next day, I'm not going to say, hey, run 6 miles. It's going to get worse and worse. It's just common sense to me. I've been there 17 years, and it's the only way I've ever done it. I couldn't imagine doing it any other way.
Well, Rob, it's not just common sense, it's evolution. If you think of evolution and the reason why evolution or God or whatever you want to call it gave us symptoms, symptoms are there for a reason.
Keep you alive.
It keep you alive and adapt and be able to survive in an environment. They've been there since the beginning of mankind. So like you said, if you have a rocking issue, you're not going to keep running. The body gives us pain to let us know, don't do that, because it needs to heal, right?
You know, I'll have a patient comes in and they'll say, I've had this neck pain or the shoulder pain for about a month. I went to the doctor, he gave me an injection, I feel great. I said, no, you don't feel great, you don't feel anything. They're numb, nothing, no pain, nothing. I say, well, that's not really good. They say, no, I feel great. I go, listen, you don't feel anything. Doesn't mean you feel great. Your condition, your discs, your herniations, of whatever might be going on, is getting worse and worse and worse. You just don't feel it. Come back in a month or two when that medication wears off or the inflammation comes back, you're going to be screaming and saying, what do I do? Please help me.
Right.
So it's got to come
And then they
together.
come back. Then they come back and they turn around and they say to you, "No pain, no gain." Right? We've heard that before. But really, pain and symptoms. It's taken thousands and thousands of years for development of these symptoms to protect us as a species.
Of course.
Perfect example I'll give, which I love to share with my patients all the time, and I think you'll agree with me, is medically, the medical profession traditionally has been trained and geared to suppress symptoms and treat symptoms. For instance, you get a cold, you start to sneeze, you start to cough. There's a reason why we do that. If we have bacteria or viruses replicating within our respiratory tracts or in our sinuses or noses, that's our body's way of getting those viruses and bacteria out so they don't stay there and continue to reproduce. What do? First thing we do is we take a medication that stops that from happening so we can feel better.
You're speaking my language. We come from the same school.
Right.
I've been preaching this for almost 20 years.
But a lot of the people in the audience, they don't understand that symptoms are healthy sometimes, unless they're going to kill you. Then you want to suppress them so you can survive. But another example, you eat something, you get food poisoning, you have massive diarrhea. It's not a pleasant thing, and nobody wants to have massive diarrhea. But when you have those bacteria replicating in your GI tract geometrically, that's what's making you sick. And now if you take something to stop the diarrhea, it keeps them in there so they can replicate more. Your body's trying to flush out.
Right.
Babies who develop fevers, okay? First thing parents are taught to do is, if it's 100, 101, give them Tylenol, get that fever down. Whereas research has shown, I'm sure you agree, that if you take a test tube and you put a bacteria in there and you now increase the temperature of that substance with white blood cells in there, for every degree that temperature increases, the white blood cells engulf 10 times more bacteria. So our bodies raise our temperatures so our white blood cells can become more stickier to engulf more bacteria and viruses. So there's a reason why we have these symptoms.
Of course.
Now, obviously, if a baby has 104, 105, 106 fever, you want to give them something to bring it down because you don't want them to go into seizures or convulsions.
Of course.
But the hardest thing for a parent is that, oh my God, I got to hear my baby cry and be in pain, without the understanding that that fever is helping them. you're too young, but my grandparents used to tell me that the way they handled fevers years ago was that you put them in bed, you cover them up with 4, 5, 6 blankets, and you give them a hot toddy.
It works.
And what that did was raise the person's body temperature higher to burn out the infection. And when the person broke into a sweat, you knew it was over. The fever broke.
Sure. I tell patients when they come to the office for whatever it is, hand pain, neck pain, whatever it might be, that pain you feel is kind of like your car's check engine light going off. It's letting you know something's wrong. If you didn't feel pain, for instance, you have a tear in your shoulder, you can keep working and working and working until your arm almost came off. You wouldn't realize you had a problem. Pain lets you know something's wrong.
Right.
Pain comes into the office. We go ahead and treat the symptoms initially to get you through the office, but eventually we're trying to correct the problem. We're not chasing your pain. Pain relief is, here's a prescription, here's an injection, thanks for coming, see you in about a month or two, and inevitably you'll come back in 3, 4, 5, 6 months, you'll need surgery because that's not going to help. So we figure out what's going on with you. The symptoms bring you in the office, we correct the problem, because that's really a big difference. We correct the problem, the symptoms go away.
Right. So, question to you, Dr. Babar. Once a patient's symptoms go away, if they've had trauma and if they've had subluxation, do they still need to treat, or is there something that still needs to be corrected sometimes?
Well, like I said earlier, our patients get them out of pain, put things back to where they belong, get them on a strengthening program where they can do their exercises, stretching, strengthening, conditioning, whatever they got to do. They start them at the office, and eventually they'll get weaned off and they'll go into a home program.
Right.
Some patients from time to time, they'll come back, something came back or a flare-up, or they'll hurt their back shoveling snow, or they'll be gardening or bowling, and they'll come back.
Right.
And when that does come, it doesn't take them a month or 2 to 3 to get healed again. It's relatively quickly because they're in good shape. They're already conditioned.
Right.
Their bones are where they belong. Their muscles feel good.
Right.
So they're not there for 3, 4, 5 months at a time. They may
Right.
come in for 1 or 2 or 3 visits, and they're good. That's where I like to keep them.
Good, good, good. We sometimes have patients that get out of pain relatively quickly, but still have weakness, they still have numbness, they still have differences in ranges of motion. And our biggest challenge is to try to explain to them and educate them that even though you feel better, there are still things which are not quite right yet that we need to do to get you in the optimal state of health. Do you find that sometimes happens too?
Yeah, I say to my patients all the time, I'd rather see you 12 times in a year, for example, like once a month, than 12 times in 2 weeks because you're dying, you can't walk, and you can't move.
Right.
Just maintain what you have. It's kind of like brushing your teeth. You brush your teeth every day so they don't get bad.
Right.
Don't brush your teeth when they hurt. Don't only fix your neck or only fix your back when it hurts. Maintain it so you never have that problem.
Right.
Don't only change your oil when your engine seizes.
Right.
Maintain it. Maintain your body. Maintain your health, and you stay good.
Right. And if people have subluxations, again, to the audience, which are bones out of place, pressing nerves, and they don't cause pain, but they cause abnormal pressure on the discs, long-term, over years and years and years, what does that lead to the patient
Well,
structurally?
basically, I don't have a model, but if you have 2 bones and you compress a disc in between, it's kind of like compressing a jelly donut. You compress and compress and compress. Eventually, that material comes out, puts some pressure on the nerve. That nerve gets irritated, gets inflamed, gives you pain. If you keep doing that over time, over and over and over again, those nerves don't just go to muscles or ligaments or tendons. They go to pretty much every part of your body.
Right.
Your heart, your liver, your lungs, and your entire body decreases its function. I always explain it like a garden hose. If you compress a garden hose, not as much water comes out, you cut down the water supply. Same with your nerves. If you compress the nerves, you're cutting down nerve supply. If I was to put a really tight elastic or a tourniquet around my hand, really, really tight, in a couple of minutes my hand will go numb. If I came back in 2, 3 years, I might not be able to use my hand. So if you compress the nerve supply in the neck, same kind of concept. You're cutting down nerve supply to the entire body, not just this one little section. So
Right.
subluxations are going to kill you really slow.
And arthritis, degeneration, early degeneration, that all happens from misalignment
Well, yeah.
of structures and then repetitive stress on those structures over time,
Sure.
right?
If you've got a pelvis, for instance, on the right that's causing you pain, and you tend to lean a little bit to the left to compensate for that pain, you don't realize it, but over time, you're walking almost like a penguin, and you're doing this for weeks and weeks, months and months, and then you say, well, why does my knee hurt, and my ankle hurt, and why does my hip hurt? It never hurt before. I just had this little bit of back pain.
Mm-hmm.
But it's kind of contagious. It's really hard to have low back pain and not have something else complicated with it unless it's corrected.
And vice versa. We've had
Right.
patients that have knee problems,
Correct.
ankle problems, and they're on crutches or they're limping, and then all of a sudden their backs are killing them
Every day.
because that's the foundation for what's above.
I'll have a patient come in with a knee surgery. They'll have a meniscus tear, or they'll get rehab. They'll feel great, and then they'll come in a week or 2 later and say, "Why does my shoulder hurt?" And I say, "Well, let me see your crutches." And their crutches are too high, and they'll say, "Well,
Right.
now my shoulder hurts."
Right.
So yeah, it's I see that all the time.
Yeah, yeah, yeah. Another thing that you do, which I also do, is called manipulation under anesthesia or stretching under sedation. I see you're dressed for today. Were you in the OR today, Dr. Bavar?
Just finished, yes.
Wow, wow. And can you explain to the audience a little bit, we've done this before on past shows, but can you just explain to the audience for a little while about exactly what manipulation under anesthesia is and who are the patients that might need it?
Of course. I tell patients there's one of three things generally happen. Either get better, no different, or worse. If you don't improve or you start to get worse after a couple of weeks or a couple of months of therapy, doctors, you've tried this, you've tried that, doctors have tried this, nothing seems to get you better. There's a procedure like Dr. Dow just said, it's called manipulation under anesthesia. You go into a surgical facility generally with the help of an anesthesiologist. We'll administer medication. Patient will be sedated in twilight sedation. Gives us the opportunity to go in there and break up the adhesions, break up the scar tissue, do things that we couldn't normally do in the office because there's too much pain. If a patient has pain and they can't rotate their neck and they're saying, stop, stop, it hurts, with the sedation, there's no stopping. We could do is whatever we got to do as easy as we got to do, and there's no restrictions. And I can't begin to tell you. I mean, honest to goodness, it's been amazing. Absolutely amazing.
The results.
Patients, letters. They send me cookies and cards, and they absolutely love it. The biggest complaint I get is, why didn't we do this 6 months ago? Or where were you 3 months ago? Or why didn't my doctor tell me about this? Or how come no one else did this with me? Can I do it again? I feel fantastic.
Right, right. Yeah, it's very rewarding when you select the right patients. And what kind of patients selection, I mean, who are the patients that need this? Every patient that comes through, or just patients that don't respond well in the office? What kind of patients and what conditions? Tell the audience, for people with certain symptoms or conditions, and what kind of patients are the candidates for something like this?
It's definitely not for every patient. Not every patient who hooks through the door gets this procedure, but patients, again, with chronic conditions, neck pain, back pain, shoulder pain, patients, for instance, with neck pain that radiates into their shoulder and they develop a frozen shoulder where they can't move it, or a therapist tries to rotate their arm and they can't move it. Patients, neck, back, hips, pelvis, we treat a whole, from top to bottom, men, women, from very, very young to very, very, some patients that are very, very heavy sometimes. We have a tough time in the office treating them because they don't respond well. But under sedation, we can do pretty much anything we want to do with them.
Right. And I think the biggest concern that a lot of the patients have is, oh my God, is he gonna stretch me too far or manipulate me too hard when I'm asleep? And what most patients don't realize is that we're trained through special training and special certification that we only go to the normal range of motion of that joint, not beyond it.
Right.
So as long as we stay within the normal range, so if your shoulder abduction is supposed to be 90 degrees, we're not going to abduct you up to way up here and possibly, dislocate the joint or do damage. We're only going to go within the normal ranges of motion of that joint.
Right.
So the chances of injury are minimal. And that's what most patients, I think, are most afraid of. And I think they're most afraid of the anesthesia sometimes too. And most patients, once they understand that we're not doing the anesthesia,
Of course.
that a board-certified anesthesiologist, that's all he does, which is called twilight sedation. No tubes, no gases in the lungs or anything like that. It's kind of like the kind of anesthesia you get when you have oral surgery. Colonoscopy. They're much more relaxed. And when we tell them a better term for it is stretching under sedation, they feel a little more comfortable. And honestly, wouldn't you agree that 90%, 95% of what we do is stretching of the muscles and ligaments?
For the large part, yeah.
And
of course.
maybe a very minor amount, hard manipulation or very gentle manipulation. So most of it is stretching to release scar tissue and adhesions which develop after trauma, which we can't break up in the office because it'd be too painful to do.
Like you said, we don't overstretch a muscle. There's an active range which the patient does by themselves. Then there's passive range which the therapist tries to move.
Right.
Then we go to a limit of anatomical integrity where you stretch right to where the muscle's supposed to be. You don't overstretch it. You stretch it back to normal range. Then there's never a compromise for the ligaments, the tendons, the muscles. We're not ripping or tearing tendons. Never, not even close.
Right.
We get them back to the normal range of motion where they're supposed to be.
Very good.
And we also check, we also check the range of motion before and after to check to see how they're doing. So it's not just, I hope they did okay. It's We've got diagnostics to prove, hey, you started with this, and now you're at this range, you've improved by that much percentage.
Excellent. Well, Dr. Bavar, I'd like to thank you very much for joining me on the show. I'd like to have you back again.
Thank you very much.
Soon someday.
Pleasure.
And for those of you who have watched our shows in the past, we have some real exciting guests coming up on future shows. And if you're interested in real wealth, join us next time on The Bridge to Health.